Director, Dive Endo India, Chennai. It's the Institute for Diabetes, Endocrine, Metabolic and Lifestyle Health. She is also founder trustee of Dive Endo India Foundation, preserving health across generations. She is a diplomat of the American Board in Internal Medicine, Endocrinology and Diabetes, senior consultant endocrinologist and diabetologist at Apollo Hospital, Chennai. And she is also associate dean of teaching and research, MD Diabetic Research Center, Ayapuram, Chennai. And she is a recipient of the Vocational Excellent Award from Rotary Club and also Dr. Sanjay Moses Oration Awards by the API Chennai chapter annual conference. Yes. So I invited Dr. Jayashree Gopal to deliver the lecture on preserving bone health in active elderly. Thank you.
Thank you, madam. First of all, thank you to Dr. Kailash for arranging this, and it's a pleasure to be here. So I thought I'll do a slightly different topic. As we all get older, we are more concerned about the effects of getting older and aging. So I thought I'll talk a little bit about what are the things we need to do to preserve bone health in people who are active and elderly. I'll talk a little bit about screening for osteoporosis and management. And just a word to say that October 20th is World Osteoporosis Day. So I'll share one thing at the end. This year's campaign is Step Up. They are talking about some 5 steps that we need to take to preserve our bones to prevent a fracture. So osteoporosis, Osteoporosis refers to both the loss of bone matrix, which is a low bone mass, which is what we detect on a DEXA scan as a low BMD. But there is also a component of a decline in the microarchitecture, and this we need to keep in mind because we cannot detect this on the DEXA. So for example, in people with diabetes, their bone density will look normal, but because they have poor quality bones, they are at higher risk of fracture. So this decline in microarchitecture is something which we can only see under the microscope, and it's not something that we can quantify using an X-ray or a DEXA scan. Hip fractures in India, these are some numbers. They start increasing in men even at a relatively younger age, about the age of 75. This is the prevalence rate of fractures, and for women also, it is higher than for men. But compared to the general world numbers, men in India are also at higher risk of osteoporosis and fractures, and vertebral fractures also, whether it's male or female. In fact, this may be partly traumatic. Men tend to have more vertebral fractures after the age of 50, even as compared to women. Women tend to have more vertebral fractures at an older age. Why is it important? Because any fracture reduces your mortality. So this is not data from India, but similar data is available. Fragility factor at any site is reduced with reduced survival. And for example, following a non-hip fracture, 1 in 11 women and 1 in 7 men can die in the first year after a fracture. Following a hip fracture, the numbers are even worse, 1 in 5 and 1 in 3. Following a hip fracture, this is from a large database in the US. They looked at these numbers. So when we think about preventing fractures, I wanted to talk a little bit more than the usual what we think about. I wanted to talk a bit more about how we preserve bones, apart from what we need to do with regard to screening, what is the current recommendation, who do we need to screen, should we be doing a DEXA for everybody. We'll talk a little bit about that. But how do we preserve bones? I think this is very important. And similar to what we were talking about with obesity, preserving bones has to start at a younger age. Particularly after the age of 40 or 50, I think it's important. So preserving bone mineral density occurs with a combination of a good diet, exercise, but it's also important to preserve our muscles. We don't pay much attention when we give advice to patients about this aspect of maintaining fitness, and we also need to think about what we can do to preserve our balance and thereby preventing falls. Some data regarding falls. It's estimated that nearly a third of all people above the age of 65 can fall, and this number increases to half of all people above the age of 80 years. Why these numbers are huge? Because 5% of these people who fall will suffer a fracture. And what are the risk factors for falls? Again, already having had a fall, a person who's had a fall is at a higher risk of a fall. A a combination of muscle weakness and poor balance because of poor fitness, visual impairment. They think a person who's waiting for a cataract surgery is one of the persons who's most likely to fall. Polypharmacy, use of psychotropic medications and other environmental hazards, the usual things, the loose wires, tripping on a rug, not having enough light, all that environmental hazards, but also some medical diseases like arthritis, cognitive impairment, Parkinson's, diabetes, depression, incontinence. Quite often falls occur when people get up in a hurry and go to the toilet in the middle of the night, alcohol consumption, having had a stroke or syncope. So these are the risk factor for falls. And there is another set of reasons why people after a fall will fracture. So people who have a low bone density to begin with, a female is more likely to fracture after a fall than a male. A person who is older, who's already had falls, particularly steroid use, history of rheumatoid arthritis, low BMI, so thin, frail, elderly, visual impairment. So we can build it up. If we have an old elderly person, particularly someone whose BMI is low, maybe we need to make sure that if they're waiting for a cataract surgery, make sure that they get it done, apart from taking all the other usual fall precautions. Diabetes is one of the biggest risk factors for disability, particularly that associated with aging, because it causes accelerated loss of muscle mass and function. I mean, there is some loss of muscle mass and strength with age, and diabetes accelerates this. And it is also associated with HbA1c. So the higher your HbA1c, the poorer your muscle quality. The poorer your muscle quality and your bone quality, the more likely you are to fall. And it is associated with more disability. Interestingly, falls are not a normal part of aging. I think a lot of us assume that as we get older, we are going to fall. Apparently, aging actually only causes disability after the age of 94 years. So all of these other problems that we associate with aging at an earlier age predominantly occurs because of loss of fitness and deconditioning, because we have not been looking after ourselves, apart from diseases like diabetes and dementia and this general negative belief of growing old. We all have this eyesight that it is going to happen, we think it's inevitable. But interestingly, apparently actual disability because of age only happens at 94 plus years. This is a fact that I saw in several articles that I read, which was actually surprising to me, because I also assumed after the age of 50 everything was downhill. But it doesn't need to be. It's only downhill because we don't look after ourselves. So preventing falls, again, these are things that we are all familiar with. Simple things like installing handrails at home, using non-slip mats, improving the lighting, making sure that our the elderly relatives always have a night light on in the night, and repairing floors and making sure there isn't anything that they can trip over. If they have uneven ground, so repair the steps and flooring. And install grab bars at home, so things for them to get up when they're having a bath or they're on the commode in the toilet. So these are all some things that can be done to prevent falls, and we can think about various other aspects to prevent falls. But what is more important, I think, is also to make sure that we are preventing sarcopenia and we maintain balance and flexibility as we get older. So this was something that I was not very aware of, so I thought I would share it here. So sarcopenia itself is defined similar to osteoporosis. Sarcopenia itself is defined as a progressive and generalized skeletal muscle disorder, which is associated with higher likelihood of adverse outcomes like falls, fractures. It's a combination not only of low muscle strength, but also of low muscle quality, which therefore leads to reduction in our physical performance. There are actually ways of quantifying it, and I just want to spend a couple of minutes talking about that. We can use a questionnaire, which I shall share in a minute, very simple questionnaire in our clinic, and we can do some simple things for assessment even in the clinic. If you want to confirm, similar to how we confirm osteoporosis with a DEXA, we can confirm using a CT scan or a DEXA scan. We were talking about quantifying fat. We can also quantify muscle lean body mass using a DEXA scan, but it's not really necessary unless you're doing a research project. And you can find out, there are many sort of classification system that tells you whether it's moderate to severe sarcopenia. So, for example, this is a simple questionnaire. There are several questionnaires, but this was a very simple one. How much difficulty you have in lifting and carrying 10 pounds, about 4 to 5 kgs. How much difficulty do you have walking across a room? how much difficulty you have transferring from a chair to a bed. So there are some of our elderly patients who just coming from the waiting area into our room itself, they need to be held, or they need to, someone needs to hold them and come in. So you know that they are suffering from sarcopenia. How much difficulty do you have climbing a flight of 10 stairs? How many times have you fallen in the past year? And all of this gets one grade. And a score which is more than or equal to 4 generally is a very good predictor of sarcopenia. And beyond that, beyond a questionnaire, you can do simple things like a grip strength using what's called a handheld dynamometer. You just have to press it. It's easily available now. And what is the amount that you can press? And also a simple chair stand test. Amount of time the patient takes to stand and sit from a chair 5 times, or how many times can they sit and stand within 30 seconds. So just make them just a simple test with a chair. We can do it in the clinic. And of course you can do more advanced things, but you can also do things like gait speed. How long do you take to walk 4 meters? And you can use a combination of the gait speed, the chair sit and stand test and balance test to determine sarcopenia. And there are numbers for it. For example, in that dynamometer, in the grip strength, the cutoff points of it less than 16 kgs for women and less than 27 kgs for men, then it is considered sarcopenia. Chair stand, if you take more than 15 seconds for 5 rises, so if I ask you to sit up and stand and you take more than 15 seconds for 5, that is a lot of time, that means you do have sarcopenia. Similarly, they have other things, gauge speed, how long does it take for you to walk 4 meters, if it's going to take you a long time. So simple tests that we can think about doing so that we at least start thinking about sarcopenia in our clinic. When we talk about exercise, we generally tell them walk, walk, walk. We also need to be counseling them about building up muscle. And this was a nice data looking at from the paper I showed earlier, showing that this grip strength, this was using that handheld what's called a dynamometer, just to measure how much you can press with your hand. You can see that it peaks between the ages of around the age of 30 years. After that, there is a decline for most people, and they use a cutoff, the numbers what I mentioned earlier. So there is an age-related decline. How do we prevent sarcopenia? A lot of exercise. I will talk a little bit more about exercise when I talk about the bones. But exercise has to be both a combination of resistance exercise and daily physical activity like household chores, apart from walking, including a lot of protein in the diet. If you're a vegetarian, making sure that you're having lots of dals. If you want to have pure protein related things in your diet, if you're a vegetarian, you can think about including some protein supplements like whey protein or soya, tofu. Those are all predominantly protein. So including a lot of protein with every meal is important. And then you can have specialized supplements. But apart from vitamin D, really we don't use it. Now another aspect of why people tend to fall as we get older is because of the change in the balance. Our balance, the fact that I'm standing here, I'm sort of moving back and forth itself is just basically, this is what we do to maintain our posture. I'm responding to my movements, I'm responding to external perturbations. Of course, the main center that determines our balance is the cerebellum, but it receives input from the vestibular system, from the visual cues, and from proprioception. Now, the proprioception involves 3 main things. One is receptors which are present in the muscle, which respond to just the movement of the hands and the change in the pressure. Receptors which are present in the tendons, and receptors which are present in the skin. The problem is, as we get older, the actual number of these receptors come down, which is one of the reasons why we tend to get more imbalanced. Why? So they've done studies and they've shown that, for example, elderly women tend to sway a lot more. Suppose I'm just standing here and I close my eyes, elderly people tend to sway a lot more because we are not able to find our center of balance. So these are all changes that do occur with age, but they're not inevitable. If we consciously work on these things and try to maintain a balance using specific exercises, we should be able to maintain it. So this is, for example, one study which showed an age-related decline in the proprioception input from ankle. So by the time you have an age of about 70 years, you can see that there is a significant decline in the proprioception. So just your ankle movement itself is a very important aspect of determining that we are able to stand upright. If you go online and look, there are lots of exercises that are recommended for maintaining balance and So lots of exercises that are mentioned. Most of them involve basically standing on one leg or just swaying back and forth. Even that is a simple exercise. For example, you can just, if it's a very, very deconditioned person, just holding on to the back of a chair and rocking back and forth, going from toe to heel, toe to heel. That itself would be very difficult for some people. With balance, under supervision, they have to do it. So there are lots of exercises that we consciously need to do. Of course, more advanced ones like these, where you hold a ball and you go on one leg, these are all more advanced. But it is important that we all work on this aspect of the fitness also for patients. Apart from sarcopenia and apart from the balance, we also can maintain our bone density with a proper diet. So a diet which is rich in fruits, vegetables, legumes, dairy products, whole grains, fish, in general these people tend to have a higher BMD, whereas diets which have more red meat and sweets, no surprises, because it probably causes more inflammation, these people tend to have a lower BMD. So diet which we know inherently to be healthy actually helps to the bones also. Exercise is important. Now, inactivity is defined as less than 30 minutes of moderate to vigorous physical activity per week. So, if you get less than that, you are considered inactive. This is data saying that nearly 50% of people above the age of 75 and 70% of people above the age of 80 are inactive. So, they are not even getting this 30 minutes of a moderate to vigorous physical activity per week. And how exactly does physical activity help in osteoporosis? What type of exercise we need to do? We need to do a combination of weight-bearing aerobic exercises. So weight-bearing aerobic exercises means our arms, feet and legs bear the weight. So things like walking, jogging, climbing stairs, tennis, tai chi, dancing, all of these where we are moving back and forth on our legs and the hands, that is weight-bearing aerobic exercise. But we also need to do some strength and resistance training, and I'll tell you why in a minute. These are the usual things where we do with weights or we do with resistance bands. So we need to have some sort of exercise. Aerobic or weight-bearing exercise has not been shown to modify the loss of bone density. So studies have done saying, just walking is not enough to preserve our bone density. You need to do strength or resistance training. So you need to do some amount of strength training exercises. And it has to be consistent. You need to do at least 3 sessions a week, at least for a year, to see some improvement in the bone density. So we need to do a combination of both. Now, you may not be able to suggest all of this to everybody, but at least I think it starts with awareness. And we can start doing it certainly. So I've spoken a little bit about lifestyle things that we need to do to preserve our bone density. Now, moving on to the other bit of it, who should be screened for osteoporosis? This is the Indian Society for Bone and Mineral Research. They published their guidelines in 2021 and they said that all women above the age of 60 and all men above the age of 65, regardless of clinical risk factors, need to be screened. That is, they need to have a DEXA done. They need to be screened for osteoporosis. Younger people, whether it's a woman or a man, if there are other risk factors based on their clinical profile, they've had, for example, a low trauma fracture. So let's say they just fell like this and they fractured either their hip or their hand, or they x-ray it down for other reasons, shows a vertebral fracture. In all of these people, you would consider doing a DEXA. People who have had a fragility fracture before the age of 50 years, or other conditions like they're on steroids or they have rheumatoid arthritis. People who have had transplants, for example, we do a DEXA quite frequently. So these are the guidelines to think. Apart from a DEXA, do we need to do anything else? We also need to get an X-ray of the spine, the thoracic spine, particularly if the bone density score is less than -1 at the spine of the total hip or the femoral neck, or if the T-score is less than -1.5 in younger people. So we also need to get a T-spine X-ray done, vertebral imaging, apart from the DEXA. In general, in the clinic, I asked them to get both done. I just asked them to get an DEXA and a thing, because anyway they are in the lab getting the thing done, so I asked them to get an X-ray. What are the basic tests we need to do? We need to do at a baseline a complete blood count, their blood sugar, urea, creatinine, their TSH, vitamin D. I mean, a 24-hour urine calcium, creatinine, that's really not needed. At least the calcium and vitamin D and a basic this panel needs to be done. Depending on if we are suspecting other things, for example, we are suspecting hypogonadism, we are suspecting hyperparathyroidism, other factors, then we need to do other tests, but these are all the extra additional tests which we don't really do. At a basic, we need to do these. The general measures that we need to take to prevent bone loss: maintain adequate calcium and vitamin D intake, limit alcohol, very important, less than 2 servings a day. This is from the Western literature. I would say in our country, limit alcohol to less than 2 servings a week. Limit caffeine intake. Stopping smoking, very, very important. Smoking is one of the biggest risk factors for osteoporosis, so smoking needs to be stopped. And an active lifestyle, including weight-bearing exercise and resistance exercise. What is the vitamin D levels we need to maintain? Preferable range is 30 to 60 nanogram per ml. Give them generally about 1000 to 2000 IU per day. Calcium, adequate dietary intake of calcium. So they don't mention calcium supplements in general. A dietary intake of calcium averaging about 1200 milligrams per day. And exercise, like I mentioned earlier, both weight bearing, balance and strength and resistance training exercises are necessary, ideally either to prevent or for people who have osteoporosis. When do we start pharmacological therapy? So anytime there is a vertebral fracture which is apparent. So for example, we do a thoracic spine X-ray and we find a fracture, or they've had any non-vertebral fracture. So any person who presents with a hip fracture, a wrist fracture or a humerus fracture, we need to consider pharmacological therapy. Or if their T-score is less than 2.5, so they have osteoporosis, or even if they have osteopenia, so the T-score is only between -1 and -2.5 at the femoral neck or lumbar spine, but what we call their FRAC score. So we go online and we calculate their FRAC score, and the FRAC score will tell us what is their probability of a hip fracture at the end of 10 years, or the risk of a major osteoporotic related fracture. So this they are talking about a wrist or a vertebral fracture. So hip fracture risk, if it's more than 3 to 3.5%, or a major osteoporosis related fracture is more than 10%, even in people who have technically the bone density in the osteopenia range, we have to consider pharmacological therapy. In people with diabetes, again this is from the Indian guidelines, in people with diabetes the intervention threshold should be, we should use a T-score of less than 2. So we don't just use a T-score of less than 2.5. Even at a T-score of less than 2 at the femoral neck or total hip or lumbar spine measured by DEXA, we have to consider pharmacotherapies, because like I said, in people with diabetes the bone quality is very poor and they are also at more risk for falls because of their sarcopenia. So again, this is just a better way of thinking about it. Any person who's had a history of a fracture of the hip or spine, or a T-score of less than 2.5, or a T-score between -1 and -2.5, if their FRAC score is higher than these numbers. So these, at this level, we need to treat them. What is the pharmacotherapy in general we use? Bisphosphonates are considered first line. Most often either a yearly zoledronic acid or a weekly alendronate or a monthly ibandronate. In general, most endocrinologists would go either for zoledronic acid or alendronic acid because the data is the strongest for these two bisphosphonates. In fact, it's currently recommended that you give 1 dose of zoledronic acid to all people who are hospitalized for a hip fracture prior to hospital discharge. Just give them 1 and send them home. Denosumab, if the bisphosphonates are not tolerated, the only drawback of denosumab is you have to give it every 6 months constantly and the cost is more. It's about 30,000 rupees per injection. Teriparatide is only recommended if they have severe osteoporosis with a T-score of less than 3.5 or they have vertebral fractures, and usually it is given only for a maximum of 2 years. In fact, in our country, most often I see it being given only for 3 to 6 months, and once you give them teriparatide as a daily injection, it has to be followed up with a bisphosphonate or denosumab. Intranatal calcitonin is very popularly used, particularly by orthopedic surgeons, but it's only helpful for temporary pain relief. There is absolutely no evidence that fracture risk is reduced long term. So we have to use only one of these 3 as a pharmacotherapy for osteoporosis or to reduce the risk of a fracture. What is the follow-up we do once we've started them on the BPD? Check the vitamin D every 6 months to 1 year. Ideal to keep it, like I said, between 30 to 40 at least. An X-ray spine is recommended annually. Again, this is all from the Indian guidelines. An X-ray spine is recommended annually, especially if they have new or worsening back pain. If it's a person who's on bisphosphonate who complains of tight pain, we have to get an X-ray of the upper femur because they may have what is called atypical fractures. It is recommended to do a follow-up DEXA once in 1 to 2 years to see if the therapy is working. And treatment failure is if the BMD is reducing in spite of your therapy. So a reduction in BMD of more than 5% in the lumbar spine or 4% in the hip means that the treatment is failing and we have to consider moving to some alternative therapy. And if the treatment is failed, we have to consider treating for screening for secondary osteoporosis. A lot of these are conditions, for example, things like primary hyperparathyroidism, hypogonadism, Cushing's, thyrotoxicosis, hyperprolactinemia, chronic liver disease, alcoholism. There's a whole host of secondary causes of osteoporosis. But this is one thing I wanted to mention. Common medications which are associated with increased fracture risk. I think we're all aware of PPIs. There's increased risk of a hip fracture after long-term high-dose therapy in several observational studies, and SSRIs. SSRIs, again, 2 times increased risk of fragility fracture seen with daily use, and TZDs. Again, these are all what we are familiar with. So, if they are on this, we need to be aware that, we have to try and stop it or remove it. And certainly, if you're going to put them, for example, an elderly person, if I'm going to start a TZD, I do a DEXA at baseline, make sure the bones are quite okay before considering using a thiazolidine diode. How long should we use pharmacological therapy? For bisphosphonates, after 4 to 5 years, a drug-free holiday is recommended if the bone density is stable. So if the bone density over the years has remained stable, is not declined, then after 4 to 5 years, we give a break and we see and repeat a DEXA 1 year after the last dose. And consider restarting the bisphosphonate if the DEXA again shows a drop in the bone density. Denosumab, unfortunately, is indefinite use. Once you stop it, the effect wears off. So every 6 months, you have to keep giving it. The advantage of denosumab is it's tolerated better. It doesn't cause any body pain, joint pain. And also in the lockdown, I found it easier to give denosumab because it is just a subcutaneous injection. People can come home and give it. Whereas for zoledronic acid, people have to go in. And with alendronic acid, the main drawback is it causes more acidity problem. Teriparatide, like I mentioned earlier, cannot be used for more than 2 years maximum. When should patients be referred to clinical endocrinologists? When a person with a normal bone density sustains a fracture without major trauma, if a person who is receiving therapy for osteoporosis has a recurrent fracture or continued bone loss without any obvious treatable cause, if the osteoporosis is unexpectedly severe or has unusual features, so a young person, for example, with several vertebral fractures, we immediately start thinking of hyperpara or Cushing's or something like that. Or if there is some other condition which is complicating management. So renal failure is one of the most difficult for endocrinologists because we don't know whether the bone is just not, it's a dead adynamic bone or the bone turnover is high. So that is the only place where we use bone turnover markers. So these are all the times when we ideally need to refer to the endocrinologist. So to summarize, fractures and falls are not an inevitable part of growing old. We have to start looking after our bones from a young age because most of our bone density we get by the age of 30-40 years. After 40-50 years, it's a slow decline. A healthy diet, regular exercise, screening and treatment for osteoporosis and preventing falls goes a long way in preserving our bones. And I just want to finish up by saying this was there's this sort of infographic which is put up on the World Osteoporosis Day website. If anybody is interested, it's available free. Just please print it up, put it up in your clinic. Their theme for this year is Step Up for Bone Health. It's on October 20th, like I said. So they go through these 5 steps. Eat bone healthy food. So lots of dairy they recommend. And in our country, I would also emphasize greens. So make sure people are having at least 1 or 2 servings of kheera every day. Greens are necessary. And of course, exercise, what I mentioned earlier, both strengthening and walking exercises, and maintaining a healthy body weight. So too low a body weight is also not good. So we shouldn't be doing, diets. Of course, the previous talk said we need to lose weight, but we need to maintain a healthy BMI. It shouldn't be the other extreme. We shouldn't smoke, avoid excess alcohol intake, and be alert to any personal risk factors. So for example, if you are on polypharmacy, poor lighting, urinary incontinence, so these are all things that increase the risk. So we need to be aware of all this, and I think it's helpful to just put up an infographic, just print it out and put it up in the clinic. Lots of patients actually read this and they may come and have questions about it. I'll stop there and thank you very much.
One thing, you never mentioned about sun exposure for this. You never said about sun exposure.
Because I never spoke much about vitamin D.
Sorry, while you're taking questions, can I?
There's so many, yes. Please. Sun exposure, extraordinarily important.
Solitary acid you give once a year, no?
Yes.
How many years you give? For 3 years?
About 4 years, 4 to 5 years, and then you do a drug-free holiday if the bone density has been stable.
Otherwise you can continue.
Just to continue. For some people, stable in the sense at least it's not going down. If it continues to decrease, there are some people who have remained on it for 7-8 years also. But the problem is after 4 to 5 years, we run the risk of that adynamic bone and atypical fractures. So after 4 to 5 years, generally we stop.
Apart from exercise, is there any medicine like zoledronic acid or other things?
Yeah, that's the slide I showed. No? Zoledronic acid, alendronic acid, the bisphosphonates, then there is denosumab, teriparatide.
That will help for sarcopenia.
Oh, for sarcopenia, no, sorry. I thought you meant osteo. Sarcopenia, nothing, only exercise. And I mean, they have these supplements, they have this leucine, creatine, non-creatinine. Creatine supplement has been shown to improve actually. They've done studies.
For osteopenia, once it stops, is it he has to continue for life?
Which one?
For
Medicine?
Osteopenia.
Yes. If it's a bisphosphonate, we give a drug-free holiday. If it's a denosumab, we have to continue regularly.
For life.
For life.
In case of vitamin D deficiency, as a maintenance dose of 2000 units, how long you have to do?
Indefinitely.
But 60K is preferred now, no? Once a week, 60K.
But that one is only for like a replacement dose. This is a maintenance. Maintenance is 1000 to 2000 IU per day, so that we don't overdose.
Calcium tablets contain.
So most of the calcium tablets contain around 400 IU of vitamin D. Unless you give 2 calciums a day, you may not reach that 800 to 1000 IU.
So only 30 and 40% is observed, madam. You will use little more.
In fact, if the guidelines, most of the, I'm saying the guidelines don't even recommend calcium intake apart from in the dairy. They've shown that only the dairy source of calcium seems to work best for bones.
Is calcium carbonate and calcium citrate both are the same effect?
Same effect. Same lack of effect, I would say, but yes, same effect. It's only to do with tolerability. Some people tolerate this better, some people tolerate that better.
CKD patients, which calcium you first time?
CKD patients, again, it's down to tolerability, whatever they can take. I don't have a problem with any. Only the thing about CKD is once they are above CKD 3B, once the creatinine is down to 35 and less, we have to give 125 dihydroxyvitamin D. Because they may not be able to convert the 25 hydroxy to 125. So we have to give them 125 active vitamin D. But it's very expensive, so we sort of, the tablet called Rocaltrol or alpha cancidol. So Rocaltrol, that's a tablet we use, but the problem is the cost. A lot of people complain.
Adolescent these days do not take milk at all, mostly. Is it okay? Leave it like that?
Most of them anyway land up taking curd and buttermilk. Even if they have lactose intolerance, they are able to tolerate curd and buttermilk, so it's okay. It's okay if they don't take milk. I think milk is a big, at least maybe now I'm more aware of it, but I think it's a big factor for gastric issues, gas and...
Now, how much sunlight helps in absorption of vitamin D?
Sunlight, very important. You need at least about, the ideal time to get exposed to sunlight is with a bare skin between 10 AM and 2 PM when the sun's rays are almost directly overhead. At other times it probably takes longer when the UV light, when the sun's rays hits your skin at an angle. So, but at that time between 10 AM and 2 PM, once you feel the burn, probably your skin has made enough vitamin D. So even at that time, even if you stand for about 2 minutes in the sun, but you need as much body exposed as possible. For women, that becomes almost impossible. The best we can say is wear one sleeveless thing and go stand on your balcony or something like that.
Will sunscreen prevent absorption or
Absolutely. It prevents absorption of vitamin D. Which is why vitamin D, I think it's important to take a supplement.
Madam,
Intranasal, what is it?
Calcium.
It's prescribed by every orthopedic.
Every orthopedic uses it, of no use. For fracture prevention, it's good for pain relief.
Only for fractures they give this.
I know.
Can't believe it. What is the subtle difference between sarcopenia, osteopenia, and osteoporosis?
Sarcopenia is muscle loss.
Only muscle.
Only
Nothing
muscle.
to do with the bone.
Nothing to do with the bone.
Osteopenia is
Only bone.
bone. Osteoporosis,
Osteoporosis is a more severe form of bone density loss. So we classify the osteopenia, osteoporosis based on what's called the PMD number, the T score. How does it compare to a 25 or a 30-year-old person of that same whatever?
so severe osteopenia is osteoporosis.
Severe osteopenia. If that T score is less than minus 2.5, it's osteoporosis technically.
You said about 15 seconds of getting up from a chair. I think I can't even do 15 seconds 5 times.
So you have to go build up your muscle. You cannot try. You cannot try.
this sitting and standing.
Yeah, standing for only 15 seconds, you must get up.
Just sitting and standing.
Try it out.
How much do you do in how many can you do in 15 seconds?
That's too short of a
That's what it is.
How much you have to do 15 times?
5.
I'm sure you can.
Madam, why is
I'm 70 plus. So.
Madam, why is male vertebral fractures earlier than females?
I think it's partly to do with trauma, is what I could. They didn't give a reason. I'm thinking it's trauma. I think a lot of the fractures in men in our country in the younger age is traumatic.
Okay. What is this bone turnover markers? Do you have any specific?
Bone turnover markers, like I said, we hardly ever use it. So there is a
This P1 and P in C-terminal peptide. So there's P1 and P. You can measure C-terminal peptide, and there are urinary markers you can measure. But we are really talking specialized territory for osteoporosis management. If your patient is into that kind of a territory, they should be under a specialist for their osteoporosis management.
Should we supplement with magnesium, madam, along with that? If there is osteopenia.
I generally do it. I always give calcium along with magnesium. It's good to do it.
And many tablets have magnesium also in them.
Yeah. Some of them, not all of them. We have to just look out for a calcium tablet with magnesium. And vitamin K is also important, which is why I was mentioning the greens.
So the sun gazing is got a better effect.
Which one, sorry?
Sun gazing.
Sun gazing.
Looking at the sun.
Oh my god. I can burn your
Looking at the
retina.
sunrise, sunset time. Sunrise and sunset, a lot of naturopathy people are talking about it.
Looking at the sun.
Sun.
Isn't that dangerous for the eye?
Sun
No,
gazing.
but that is in the evening.
Only
He
for
said. He's saying sunset, during sunset, gaze at the sun.
Sunrise, sunset time for about 5 to 10 minutes or 15 minutes.
In alternative therapy, it's given.
Not in straight seeing them.
At least in terms of vitamin D, I don't think it's very
Eyesight improvement, at the same time, the pranic energy improvement, and then vitamin D3.
Alternative.
Skin color has got anything to do with
Yeah.
Skin color has got anything to do with abdomen.
very much.
Fair people are more, dark people are
Fair people probably make vitamin D better as compared to darker skinned people. In fact, studies in India have shown that even bare-bodied farmers, they did a nice study in Andhra, but bare-bodied farmers also have a relatively low vitamin D level.
How come, madam? How is it?
Yeah, because
Because of that
dark skin,
pigmentation, melanin.
melanin.
So they're not able to make the vitamin D. So there is this whole controversy about them. You know, obviously we are surviving and we are doing well. How is it? Do we really, those levels of vitamin D, is it also important for us? Should we be looking at lower vitamin D levels? There's a whole other sort of controversy that is going on. But very definitely, if you have melanin, which is why somebody was asking about sunscreen, melanin, clothing, even wearing any sort of clothes, it cuts off the UV light. So our body cannot make enough vitamin D. It's always better to take it as a supplement. That's why.
Sun bathing should be good. Like what people do in abroad, you know.
No, we also should there is. Because all of the white people, they have easy.
White people, they sit under the sun.
They don't get enough of it, but then they are more prone to other problems. They sit sit under the sun with a lot of sunscreen.
Yeah.
Because they are more prone to the melanomas and the basal cell CAs and all that.
Thank you, Ben. Thank you very much.
Thank you.
Thank you.
Session on bone health by Dr. Jayashree Gopal. It's a program of appreciation by the from the Association of Impact.